Hi, this is Dr. Garcia. This video will review two techniques for knee joint injections. Intraarticular injections and aspiration of the knee are common and useful procedures for the daily practice. Both techniques are similar, but they have different indications. The arthrocentesis is used mostly to clarify the etiology of undiagnosed joint effusions and to relieve pain in large effusions or hemarthrosis. Knee injections are used for viscosupplementation or corticosteroid treatment. This video will focus only on techniques for knee injections. Before attempting the procedure, review the risks, benefits, and alternatives with the patient. Ensure that you review the contraindications, clearly explain the procedure, and obtain an informed written consent. Corticosteroid injections are indicated to treat knee osteoarthrosis exacerbations, in particular when effusion is present, to treat crystal-induced arthropathy, and to treat synovitis in rheumatoid arthritis. Hyaluronic acid supplementation is a step in the long-term treatment of osteoarthrosis to decrease pain, to improve functional limitation, and is helpful when delaying knee replacement surgery. Remember that in osteoarthrosis, joint injections are only part of a comprehensive treatment that includes, among others, the use of regular analgesics, physiotherapy, home therapy, rest, weight loss, occupational therapy, and cross-training. The equipment needed for corticosteroid injections includes the corticosteroid medication, 1% lidocaine, skin cleansing agent pads, alcohol pads, a 1.5 18-gauge needle for loading the medication, a 1.5 22-gauge needle for delivering the medication, a 5 to 10 cc sterile syringe, procedure gloves, and a bandage. Sometimes ethyl chloride is used for numbing the skin. Different corticosteroid agents have many differences, particularly in potency and solubility. The injection of choice varies among centers and depends on physician's preference. The more common used solutions are methylprednisolone, triamcinolone, and betamethasone. The equipment is the same for viscosupplementation, using a hyaluronic acid preloaded syringe. There are different commercial solutions available for viscosupplementation. Some of the solutions are chicken-based produced. The discussion with the patient will determine which brand is most suitable based on the specific needs of the patient, characteristics of the solution, and presence or not of allergy to chicken. First, it's important to identify the superior, inferior, medial and lateral borders of the patella, as well as the femoral condyles and joint line. There are 6 possible points of entry or portals. 2 superior, 2 inferior, and 2 mid-patellar. For example, this will be the portal for a lateral inferior approach, and this will be a lateral mid-patellar. For the inferior lateral approach, a soft spot will be felt between the patellar tendon, the patella, and the femoral tibial joint. If the patient is lying supine, the lateral mid-patellar, medial mid-patellar, and superior approaches can be used. If the patient is sitting with the knee flexed at 90 degrees, the anterior medial and the anterior lateral can be performed. Establish the anatomical landmarks, find the injection site, and mark it with a close end of needle cap. Clean the area with antiseptic solution twice in an outward spiral motion. Then, dab it with alcohol. Without touching the sterile area of the skin, insert the needle at the previously explained point of insertion. When injecting hyaluronic acid, avoid drawing back on plunger. Administer the injection slowly to avoid discomfort. Maintain consistent pressure. The solution should flow easily without significant resistance. Always maintain a sterile technique during the procedure and keep holding the syringe in a correct position. When done, withdraw the needle rapidly and apply pressure on site. Then cover with a bandage. With the patient lying supine, with the knee slightly flexed to about 5 degrees, establish the landmarks and cleanse the area as previously explained. Insert the needle at the point of insertion and direct the needle towards the opposite patellar midpole. In this case, notice that the doctor's thumb was kept maintaining mild medial displacement of the patella. The bulging area observed is an area of effusion, not the patella. Keep administering the solution slowly and always maintain a sterile technique. When done, withdraw the needle, apply local pressure, and cover with a bandage. Possible complications are septic arthritis, bleeding or bruising, blood vessel and nerve damage, facial flushing, anaphylaxis, needle fracture, syncope, and systemic effects. For corticosteroid specifically, post-injection steroid flare-up, subcutaneous fat atrophy, skin depigmentation, soft tissue calcification, and synovitis. Contraindications: skin breakdown, infection at the injection site, bacteremia and sepsis, hypersensitivity to the medications, uncontrolled coagulopathy, osteomyelitis, joint replacements, hemarthrosis, and joint prosthesis. Caution is advised in patients with anticoagulation. After the injection is administered, advise the patient to avoid major physical activity involving the injected knee for 2 to 5 days after the procedure. Schedule a follow-up visit 3 weeks after the procedure.